Presentation, which is safety and efficacy of a leadless pacemaker, results from the LEADLESS II clinical trial from Vivek Reddy.
Thank you. So this is the LEADLESS II clinical trial that I'm going to show some of the data from. I do have a conflict of interest. From St. Jude Medical, who's the manufacturer of the device in question, I received grant support and I serve as a consultant. And I am discussing a non-FDA approved device, though this device is approved here in Europe. Whatever. So just a quick background. I just want to point out first that regular pacemakers, standard pacemakers, are very reliable devices. They've been around for over half a century, and we like the devices. Having said that, they're not perfect. The devices consist of the device itself, which is placed surgically in the chest, and a lead, which is the wire that goes from the device through the vasculature to the heart itself. And there are problems with both of these components, both from a surgical perspective, particularly in patients who have diabetes and renal failure, and then the leads themselves can have complications. And it was because of these reasons that there's been an interest in trying to avoid both the surgical pocket as well as the lead itself. And the concept is what you see here. This is the first such leadless pacemaker device that was introduced. The device itself is about 4.2 centimeters long, 6 millimeters in diameter. So it's delivered transfemorally. So this is a percutaneous procedure. It's delivered transfemorally through an 18 French introducer. The device is placed entirely within the right ventricle. So here you see the device next to a dime, because I should have shown a European coin. But anyway, this is what I have. The device itself, again, it contains both the battery, the electronics, as well as the pacing lead, which is at the tip. There's a helix at the tip, which allows the device to actually fix to the myocardium. Now, because of the way the device is delivered, there is no surgical pocket, and that's one potential advantage. Also, the absence of a lead makes this inherently MR compatible. Now, that still remains to be proven, but at least in theory, there's no reason why this should not be MR compatible. It does have some of the conventional features of traditional pacemakers, albeit not all of them. It does have rate responsive capabilities, so as the patient is active, the pacemaker will pace faster to try to accommodate to the higher cardiac output that's necessary. The estimated battery life is over 10 years. Hysteresis and magnet modes, other sort of features that are common to regular pacemakers. And there is also the capability for retrieval. So after the device is implanted, the back end of this device, this little hub, can be captured with a snare, and then the whole device can be unscrewed and removed. And here's just an example of the device in a right ventricle on one of our patients.
Okay, check distal catheter deflection.
Oh, that's actually, okay, sorry.
Okay.
So the device is actually delivered with a catheter. So there's a catheter that hooks onto the back end of the device, advanced into the heart, and then put into position. So the LEADLESS II trial follows the LEADLESS I trial, which is the first-in-man experience at a small number of centers. The LEADLESS II trial is a much larger trial. It's a prospective, multi-center, non-randomized study, and this is an FDA IDE study. The objective was to evaluate the feasibility, the clinical safety, and efficacy of non-surgical implantation of this device in patients requiring single-chamber ventricular pacing. The pre-specified analysis was to look at two cohorts, which I'm going to be talking about in the rest of this presentation. The first cohort consists of the first 300 patients enrolled in this trial followed out to 6 months. That happened in June of this year. At that time, we had enrolled an additional 226 patients, obviously not followed quite as long. So that's the total cohort. So there are two cohorts that I'll be talking about. The primary endpoint is for the primary cohort, the 300 patients followed out to 6 months. This is by intention to treat. The safety endpoint is looking for freedom from serious adverse device effects at 6 months. The efficacy endpoint was looking at all of these components: acceptable pacing capture threshold, therapeutically acceptable sensing amplitude out to 6 months. I should note, again, this is multi-center, 56 centers in the US, Canada, and Australia, 100 operators in this trial, and of which only one operator had prior experience with leadless pacing. So these are the outcomes. The device was successfully implanted in about 96% of patients. This is both in the primary cohort as well as the total cohort. If you look at the primary safety endpoint, 280 of the 300 patients achieved the endpoint, give you a 93.3% success rate, and this exceeded the performance goal of 86%, and there's the p-value. This is the primary efficacy endpoint. 270 of the 300 patients achieved this endpoint, 90%, again exceeding the performance goal of 85%. There was also another efficacy analysis for those patients who had successful implants. That is, of the 300 patients in which the implant was attempted, 289 patients actually had a successful implant. Follow those patients out to 6 months, and it turns out 93.4% of those patients achieved adequate sensing and pacing thresholds. Also, based on the device use characteristics over these first 6 months, the battery longevity is estimated to be 15 years, the mean of 15 years, and you see the range between 14.2 and 15.8 years. At least that's a 95% confidence interval. These are the device-related serious adverse events, and I apologize for this. I should note, by the way, this just went online in the New England Journal, so you can access the full manuscript if you want. So these are the overall complications. If you look, and I'll just concentrate on the total cohort because that encompasses all 526 patients. What you see is the overall major complication rate is 6.5%. If you look at cardiac perforation, it was 1.5%, and this includes a total of 8 patients, 6 of which required intervention, 2 of which did not require intervention. That is, they had pericardial effusion, but this was not hemodynamically significant and therefore was not tapped. There were 6 patients with vascular complications, which constitutes 1.1%. There were 3 patients who had arrhythmia during device implantation, and 6 patients who had device dislodgement. That is, after the time of implantation, within the first couple of days after the implantation, the